Morning, everyone. I think we, Madam Clerk, let's take roll, please. Okay, we have a quorum, and thank everybody for being here this morning. So, first up, we'll hear House Bill 1389, Delegate Anderson. Good morning.
Good morning, Mr. Chairman. If I could, I do have a couple of amendments to 1389. I can explain them.
Sure.
1389 erroneously uses the word controlled substance, which is defined under the law's Schedule 1 through 4 drugs. Everywhere in the between lines 60 and 67 where the word controlled substances is just substituted with the word medication.
Move the amendment.
Second. Is there a second? Any discussion? Hearing none. All in favor say aye. Opposed, no. Amendment is before us.
All right. Members of the committee, Virginia law allows minors to have medical autonomy in certain areas. One of those areas is receiving medical health care, outpatient care for treatment and rehabilitation of mental illness, emotional disturbances. Virginia law is permissive on the fact that doctors and providers can prescribe medication to children for the treatment of mental health illness. It's permissive. Doctors are allowed to do this. The FDA has a black box warning on SSRI antidepressants. It's the strongest warning the FDA can give in any medication, and it says minors that take SSRIs actually can have increased suicidalities. This can actually make their initial conditions worse. So what Virginia law allows is it boxes the parents out of, one, having any knowledge of the fact that their children might be prescribed drugs like SSRIs, and two, keeping them boxed out from the treatment plan if their child is severely depressed enough to be prescribed medication. So all that 1389 does here is it just says that if a doctor needs to prescribe a medication for the treatment of mental health illness, they have to bring the parent into the equation. And that's it.
Thank you, Delegate Anderson. Anyone, committee, have any questions? Delegate Hope?
Delegate Anderson, do you think that this could have a chilling effect on minors coming forward to seeking medical treatment, mental health treatment?
Mr. Chairman, Delegate Hope, I'm very concerned about a minor that might be at school and they may feel sad or depressed, and I would want them to have that autonomy to go to the school psychologist and talk their way through that. And there's lots of ways to address that, talk therapy and all of those things, but if it's so bad that we need prescription medication for treatment, in my opinion, we should bring the parents into that equation, especially if they're severely depressed and prescribing the medication may make them more suicidal. I think parents should at least have the knowledge of what's going on so that they can be aware, so that their child doesn't commit suicide. So I don't think it will have a chilling effect. I'm not trying to take away the minor's access to the doctor. It's just when it gets to prescribing the medications for this, I think the parents should be brought into the equation. And Delegate Hope, that would be required in other areas as well. If your child had a serious infection and needed antibiotics, the parents would have to be brought into that equation. Or if you had to take even certain vaccinations, you have to get parent COVID vaccination. You have to have parent consent. So that's already the law. It's just there's this little carve out with mental health, and it's permissive to let these medications be prescribed.
Delegate Waxman, you have a question?
Thank you, Mr. Chair. Delegate, I had a question about, I guess it's really about the amendment. Didn't have a chance to really fully digest it, but medications in general would that also not capture some non-prescription medications too? Well,
the child could do that himself, right? I mean, there's no reason a child couldn't go in and buy Tylenol from a Walmart, correct? I mean, they would be able to do that. We just thought medications was the best word. Controlled substances is not the right word because that's a class 1 through 4, as you know. So LIS thought the best word was medications. I'm open to a different word. You're the pharmacist. If there's a better word, I'm fine with it being SSRIs, but they just thought medications was the best thing for prescribing.
Okay.
Anyone in the audience like to speak in favor? Please come forward and state your agency. Anyone in the audience in opposition?
Good morning, Chairman and members of the committee. Emily Moore with Voices for Virginia's Children, and we strongly oppose this bill. This goes against current practice that allows medical autonomy for older youth and would ultimately constrain some older youth from receiving the mental health treatment that they need. Virginia currently ranks 48th in the nation for youth mental health, and one contributing factor is access to mental health care. Stripping youth of their autonomy and the ability to make decisions regarding their own mental health needs will further limit their ability to have access during a time when mental health needs are increasing. So we ask that you strongly oppose this bill. Thank you.
Thank you. Delegate Hope, you have a question for
I
the
do have a follow-up question.
speaker?
So you mentioned, Delegate Anderson, about the issue of suicides, but nowhere in the bill does it talk about that particular side effect. And so it says, so it's required for any medication whatsoever. If a medication is going to be prescribed, therefore, the parent has to be notified, whether it has these negative side effects that you mentioned at all. Isn't that right? I don't
Well,
see this in the language.
Sure, Delegate Hope. That's so in the
And I
context.
see nothing in here about FDA's warning
Delegate Hope.
label at all as well.
Sure. So in paragraph 60, it talks about mental health treatment. And so if a mental health provider thought that the course of treatment to deal with depression is an SSRI, that would be a medication that would require parental consent. If the mental health provider thought that a prescription of Advil was necessary, the child can pick that up himself without parental consent. And so my point here is I'm totally fine with replacing the word medication with SSRIs. And I've told legislative services that it was their suggestion that we just make it medications. If you want to propose SSRI, replace medications with the word SSRI, I absolutely consider that a friendly amendment. That is the biggest one that concerns me. Look, I'm a parent. Most of us are parents. I don't want my kid getting an SSRI that may increase their suicidality without me even knowing about it. That's what this bill is really about. So if you want to make that amendment, I would accept that. Or
Mr.
anyone.
Chairman, I wouldn't vote for the bill because I do think it will have a chilling effect for kids coming forward, because there might be a very good reason why they don't want to come forward, and they may not seek the care that they need. And you know what happens when people don't seek the care that they need for a mental health situation, don't we? That concerns me.
Let's hear from the queue. I think we have Ms. Tatus. Is that correct?
Yes. Hello. How are you doing?
Good morning.
Good morning. So my name's Ann Tatus. I'm co-founder of Virginians for Children First. And this bill, I've gone back and forth about opposing or recommending, because we continue to layer law upon law that ignores standing law, that parents in school, parental rights is not a myth. There is standing law that parents are to be notified once a year of all counseling services to opt their children out. The saying that to remove parents and children's medical autonomy goes against the constitutional God-given right of parents to direct and including medical health. The suicide rate is up in children because they are teaching mental health to children in every classroom without parental notification or involvement. This mental health crisis is up because they've removed parents and given children who do not even have have not even reached the age of cause and effect in their brains yet, the medical autonomy. We have to go back to reason. And so I originally was yay for this, but I feel like we are going to layer more law that suppresses the actual parental right the Constitution and the Supreme Court over the last 100 years have given us. And we continue to give away fundamental rights as parents. And the government has shown, because you've been doing this for 10 or 15 years, you have made the problem worse. And we need to actually address the problem and bring the parents back to the table in the involvement of this.
Thank you, Ms. Tatus. Next,
You're
we
welcome.
have Mrs. Gregory.
Good morning. Yes. So I'm Kim Gregory. I am a licensed clinical social worker. I work with an agency that specifically deals with adoptive and foster youth. And I would certainly oppose this because from at least the population that I work with, there is a real lack of access to mental health care in general, as well as medication for children who really need it. And when you layer on the difficulty of not having a guardian who they may feel comfortable with or connected and attached to, they are absolutely going to not reach out for services. And so I think that we really need to have children learning that they can be in charge of their own bodies, especially children who've gone through abuse and neglect, which is the population, again, that I work with. So I would oppose this from a professional perspective, knowing that these kids are really hard to get into my office and they really need supports and to be in charge of who they are and their physical being.
Thank you.
Thank you.
All right. Next, we have Ms. Nichols.
Yes, thank you. It is in the Virginia Constitution that parents have the right to guide and control their children. If you look at Nazi Germany, kids were promoted over those who are older. There's a 5-part series called Hitler's Children that details how they were used by the state for its own purposes and their families and the detriment. I think the main question that I have, why is it children are always hiding things from the parents, but it's okay for the state to stick their nose in there? The state is absolutely not the controller of kids. It is the parents. And that's what disturbs me on anybody having an issue with this bill. The state should be promoting relationships between parents and their children. Thank you.
Thank you. And I think lastly, we have Ms. Merriman. Ms. Merriman, are you here?
Yes. Excuse me.
Good morning.
Good morning. Hi, my name is Ashton Merriman. I've been in the mental health field for 7 years, working in both inpatient facilities and outpatient facilities. I see clients as young as 4 years old. Some people find it hard to believe that a 4-year-old would need mental health care, but I'm here as a professional to tell you that it happens far more often than we would like to believe. My job is to partner with parents to help them help their children, to empower the family unit. But before that can happen, I need to see the client. We understand that around the age of 12, children can begin to comprehend more abstract cognitions and conditions about the human experience. However, this is also occurring at the same time that children are experiencing severe bullying and harassment and just school in general, which we all know is a hardship. And so once we get children the ability to empower themselves, to reach out for help, we can empower them to get the help and the care that they need. Again, to lower suicide rates, to empower them to involve the family unit. As a therapist, we encourage and promote a system of care. And when safe, that involves parents and guardians. I am in favor of giving children access to their mental health care needs so that we can see children live to adulthood. As a mental health professional, it is my ethical responsibility to give autonomy to each and every one of my clients, no matter how old they are. But I'm also here to walk with them, to encourage them to get the support they need, not just in their mental health life, but in their family systems, in their school life. This is impacting children's ability to open up and get truly the well-rounded holistic care that they need. Thank you.
Thank you. I think lastly is Ms. Copenhaver.
Hi, thank you for hearing me. I didn't get a link, but I was sent one from someone else. So, as a mental health care professional that works predominantly with teenagers, particularly those within the foster care system and within the LGBTQIA population, I can attest to the disservice of this bill. According to the National Prevention of Youth Suicide, suicide is 3 to 5 times more likely in youth in the foster care system and up to 7 times more likely for LGBTQIA youth than their cisgender peers. Oftentimes, DSS can take several months to return paperwork in order to enroll or continue in mental health care services due to lowered labor in this field. And many adolescents have a difficult time talking to their parents about their thoughts of suicide or self-harm. What we also know that completed suicide can be contagious, especially among our teenage populations. Once a peer completes suicide, it can feel more accessible to others, creating a destructive chain effect in our communities. Therapists oftentimes stand between the threat of suicide or self-harm of our teenage clients and finding relief, helping teens process through their difficult feelings and finding ways to speak to the adults in their lives about these concerns. To take away the anonymity of mental health services within our teen population is putting them at a greater risk of the suicide epidemic. Thank you for hearing.
Thank you, Ms. Copenhaver. And we have a lot of questions from members of committee. So we'll try to, if you don't mind, make your comments and questions brief. Delegate Orrock.
Yeah, Mr. Chairman, this maybe is, I'm not sure, medical society, whomever. What I want to try to get to is, do we need to have some latitude here for the emergency treatment and prescription of some of these medications, i.e. they present in the ER and they're in a crisis situation. Are there meds that should be administered at that juncture and could be administered, but we would still preclude their long-term administration without the parental consent? I don't know if that's something medical folks could answer or a distinction without a difference.
I think he's got a phone a friend here.
Morning, Mr. Chairman. Scott Johnson is General Counsel for the Medical Society. Delegate Orrock, we are concerned about the emergency situation. We obviously are catching up on the substitute as it's run out, but to Delegate Hope's comment, the last thing we want is a kid not getting the medication they need because we know they'll end up in the emergency room, and so that is a valid concern amongst others you've discussed.
Mr. Chairman, follow-up?
Delegate Orrock.
So would it give some comfort if we clarified that this is only in a non-emergency situation, they couldn't do these without the physician, the parental consent?
Mr. Chairman, I would say to Delegate Orrock, that's one point, but remember that oftentimes under our code now, a minor is deemed an adult for purposes of getting certain treatment, and that includes some of the mental health treatment. So you got to figure out how this bill would run counter to that.
Thank you.
Yes, sir.
Delegate Adams, you have a question?
Yes, Mr. Chair, and this is in follow-up to Delegate Orrock's, but I think kind of ties the things together. I think for the purposes of this particular bill, I would like to take you up on your offer to change the word medications to SSRI, since that was the intent. In an emergency situation, an SSRI is not going to be the drug of choice, so that would solve both problems. So if it is still agreeable with the patron, I would move that we would have a substitute where we're striking the word medication and put SSRI in its place.
I would accept that as a friendly amendment, and I think that would be 3 changes. And then if we could use, LS, could we use the real word, the serotonin, rebuking, whatever it is, the full word?
So, okay, I was going to say we have a motion and a second. Any discussion? Hearing none, all in favor say aye. Aye. Opposed, no. That amendment is before us.
Mr. Chairman, only to the last comment, this bill doesn't affect a minor's ability to go seek mental health care treatment in any way. They can still go to the psychologist, they can still have the autonomy, they can still seek the talk therapy, they can still do the other therapies. It just would stop that prescription component without the parents being involved.
Thank you. Delegate Guzman.
Thank you, Mr. Chairman. It's just speaking to the bill.
Delegate Guzman.
Thank you, Mr. Chairman. I am a parent, and many on this room and legislators are parents as well. I am blessed to have a parent as child with mental health, with a mental health diagnosis. And as a parent, I've never felt out of the loop during his treatment. And some concerns were brought up about communications in between parent and children. That is not something that we could legislate in this chamber. I would say that is something that you have to work with your child and your family to improve the communication system, but that is not going to improve, the treatment of the illness that your child is facing with. We heard some comments about children getting over-the-counter Adderall. I would say that is false. My child takes Adderall, and there's a lot of, consents and approvals that you go through the pharmacy, that if your doctor has not approved a prescription or refill, you cannot take it. So I just wanted to talk on behalf of those parents that we do consent treatment for our children to get better in mental health. We feel that we have the systems that they are working now. And also, for those children where they don't have the support systems, because we need to acknowledge, and I believe that this body has made a great job as far as empowering children and empowering them to seek the treatment that sometimes don't even understand or their families don't understand, is to be able to seek the help of a therapist or a psychiatrist so they can understand what is going on in their mind and with their mental health needs. So I just want to make those points, Mr. Chairman. Thank you.
Mr. Chairman.
Delegate Anderson?
Just one point. Delegate Guzman, I didn't say Adderall, I said Advil, just ibuprofen, just to that point.
All right. We've heard a lot of discussion on this bill. Committee works on motions.
Move to report.
It's a motion to report.
As
Is there a
amended.
second. As amended. Substitute as amended. Was it a substitute?
Just
It was. Yeah. Okay. As amended. Okay. Was there a second to that motion? Okay. Here was a second. And any discussion? Hearing none. All in favor to report as amended, vote yes on the board. Motion to report passes 6-3.
Thank you.
Thank you, Delegate Anderson. Next, we have Delegate Durant. Good morning. House Bill 1945.
Good morning, Mr. Chair.
Good morning.
House Bill 1945, there is an amendment. It should be available online now.
Okay. Is there a motion to move the amendment?
So moved.
Second? Second. Any discussion? Hearing none. All in favor say aye. Aye. Opposed, no. The amendment is before us. Delegate Durant.
Thank you. Mr. Chair, this bill was brought to me by staff at the Community Services Board as a means by which we can reduce the overburden administrative requirements in data collection. Over the last several years, the amount of time needed to in-process an individual for services more than doubled. What used to take 45 to 90 minutes now takes anywhere between 2 and 4 hours. Many of our CSPs are understaffed, and this administrative burden is overwhelming. According to CSB administrators, there is no way to get a complete data set via CSBs or this CPM team, which is the Community Policy Management Team, groups listed in the legislation. Similar and more complete data points are collected elsewhere, leading to duplicated data reporting and requirements and compounding the administrative burden. This bill removes costly and burdensome administrative requirements which do not provide sufficient information to increase accountability or support system improvement activities. So in summary, this reporting is an administrative activity with no known impact on ensuring appropriate coordination or care for individuals served. The incomplete data sets do not provide any increased accountability or solid information which could be used for system improvement. And of course, as I said, the data reporting is duplicative. I have worked very closely with BDHDS and several members of the team. And so as amended, also with the Attorney General's office. And so as amended, this bill has satisfied their concerns with conformity to the DOJ settlement, and I'm not aware of any opposition to this bill. Hope it answered any questions.
Thank you, Delegate Grant. Any questions, committee? Anyone in the audience like to speak in support? House Bill 1945? Anyone in opposition? We do have anyone in the queue, Madam Clerk? Ms. Tatus, again. Good morning.
Good morning again. Again, this is another bill that, with the Virginia Consumer Data Protection Act in effect that on January 1st went into effect, that nobody in the entire state is enforcing because it falls on our Attorney General to limit when we have 400 to 500 data points on children, again, with the Virginia Consumer Data Protection Act and the Children's Online Privacy Protection Act, amongst many other federal and state laws, not being enforced. To vote in favor of this as someone who advocates for all children and the data collected on them is going to impact their futures forever. To acknowledge this and not all the entire systemic problem of data collection, I would be remiss to, again, vote in favor of something that is a symptom of the disease and not actually going after the disease itself. Thank you.
Thank you. Delegate Adams, you have a question?
Yes, Mr. Chair. Is there somebody from the department here to speak to this bill? Thank you,
I did have someone from the CSPs that were supposed to be here, but they're at Disney. So unfortunately, she's not here. But Mr. Chair, if I may.
Delegate Grant.
Yes, I have been hosting a series of behavioral health forums in my district and bringing several stakeholders to the table and to discuss some of the challenges. So this was a couple of things that they shared with me that could help reduce that administrative burden. I know it's a small way to move the needle, but they said it would make a huge impact, and maybe residually it will go directly to the heart of the burnout that we know staff members are experiencing when they are sitting down and going through 2 to 4 hours of intake. If we can reduce some of that, especially when they can see that it's not achieving what it's set out to do, and there are other ways that this data, as intended, is being collected elsewhere, I think it makes the most sense. Thank you, Mr. Chair.
Thank you. Committee works on motions.
Move to report.
I have a motion to report. Is there a second? Is there a second? Okay. As amended or substitute?
Sorry, as amended.
Okay. All right. Any discussion? All in favor, vote on your board, please. Motion to report passes 5-1 with one abstention. Thank you, Delegate Grant. Delegate Hodges, I see you. Like to go ahead? Good morning.
Good morning, Mr. Chairman, members of the committee. You have before you House Bill 2435, and up first, I believe there's a substitute. A late last night draft. Thanks to Mr. Brooks.
You'd like to tell us what the substitute does?
Sure, I can. And also, if we can get the substitute before us, there is a technical amendment. I was advised by the Attorney General's office just to change something that's fairly simple and then some wording, if that works for you, Mr. Chairman.
Sure. And I remind the committee that if this is looked upon favorably, it would need to go to appropriations. Do we have a motion on substitute? A motion and a second. Any discussion? All in favor say aye. Aye. Opposed, no. The substitute's before us. Thank you.
Thank you, Mr. Chairman. And there is a minor technical amendment on lines 58 and 59 to strike Consumer Protection Division and insert the Division of Consumer Counsel.
Okay. Do you have a motion on that amendment? Second?
And I can send that in electronically to Mr. Brooks as well.
Okay. Any discussion? All in favor say aye. Aye. Opposed, no. That amendment is before us. Delegate Hodges.
All right. Thank you, Mr. Chairman. Last session, we had bipartisan support for legislation regarding advanced estimate of payment amount for elective procedures, tests, or services in hospitals. And it states that every hospital shall make available to the public on its website a machine-readable file containing a list of all standard charges for all items and services provided by the hospital. And what this did is it adopted existing federal standards for price transparency into Virginia law, in part because the federal government, even though it was part of federal law, they've been reluctant to enforce this law. So we had bipartisan support for this bill. And since that law took effect in July, the Department of Health has evaluated a sample of hospital price transparency websites, and VDH staff has observed that most of the 67 facilities licensed as outpatient hospitals do not comply with hospital price transparency requirements, even though they're required to do this under federal rules and now actually under Virginia law. So with this substitute, basically the original bill required civil penalties, and I think that was probably what led to the fiscal impact. So we've tried to tone it down a little bit, change things a little bit. So with this substitute, what it does is it removes the civil penalties. It still requires a plan of action by VDH, and it requires reporting of non-compliant hospitals to CMS. So VDH will report those to CMS, and it requires non-compliant hospitals from initiating debt collection actions against patients who received services during this time of non-compliance. In addition, it still maintains that it's a violation prohibited under the Consumer Protection Act for repeat offenders, and those will go to the AG's office. So that's basically what the bill does.
Thank you, Delegate Hodges. Anyone committee? I don't see anyone in the queue. Well, Delegate Waxman.
Thank you, Mr. Chair. If I could ask the delegate, I'm hearing that CMS or the federal group wasn't enforcing their law, but it's a relatively new law, isn't it? And hasn't CMS recently started enforcement?
Fairly new. It actually, that law was in effect prior to Virginia passing the legislation in last session. But we know how the federal government is. They pass laws all of the time, and they don't enforce them, and they don't move forward. Consumers in Virginia need protection, and this is the law. So we're trying to find a way to give them that protection.
Now that CMS is starting to enforce them now, from what I'm being told,
I only know of one hospital that's actually been fined by CMS in Georgia.
Are we putting the hospital?
Delegate Waxman.
I was just curious. If I could do a follow-up, are we putting hospitals in a position where they're going to have to do one set of rules for the feds and another set of rules for the state?
No, no, sir. If I may, Mr. Chairman. No, we are not. What we're saying is VDH, if you see there's noncompliance, you shall report those to CMS, because CMS really should have an obligation to report back to VDH on this. And that's what we're looking for in those noncompliant facilities. Then the patient is not on the hook for debt collection after that point. So we're trying to find that conduit between VDH and CMS.
Delegate Adams, you have a question?
Yes, thank you, Mr. Chair. Is this bill in response to negative outcomes from the bill we passed last year?
If I may, Mr. Chairman, yes, because what we're finding is in VDH's survey, they found those 67 facilities are non-compliant and not following Virginia law. So they're non-compliant at this time, and we need to try to find a way to get those facilities into compliance and have some type of mechanism that helps consumers. And really, this is turning into a consumer protection bill.
Follow up, Mr. Chair.
Delegate Adams.
So the legislation that we passed, it's already gone into effect, and as a result, we feel like we need to add more scrutiny and follow-up. Is that correct?
That is correct.
Thank you, Mr. Chair.
Okay. Anyone in the audience like to speak? Delegate Price.
Mr. Chairman, thank you, and Delegate. I'm sorry. The effective date for the legislation that we passed last year was when?
July 1st.
Of what year?
Of last year.
I'm
sorry. It's effective July 1st, 2023.
Okay.
But they're still not into compliance, and what we're trying to do is bring that into conformance to get things started.
Delegate Price.
I just, we can continue to have the conversation. I just wanted to make sure I hadn't misread that the bill that we're trying to add to has already gone into effect or not.
July 1st, if I may, Mr. Chairman, that bill goes into effect July 1st, 2023.
So we're adding to a bill
So
that
we're
has not
adding
gone
to
into
a bill
effect.
that hasn't gone into effect, but we need to have some protection for our patients and our consumers moving forward.
Okay. All right. Let's go ahead and hear from the audience. Delegate Adams, one last question for you.
Yeah, Mr. Chair, so then I just want to clarify, because the response that you provided to me was that it had gone to effect. So now we're
Went into
clarifying
effect.
that it has
I'm sorry,
not.
and I apologize, Mr.
Thank
Chairman.
you,
It
Mr.
goes into
Chair.
effect July 1st, 2023.
Okay. Anyone in the audience like to speak in support of House Bill 2435? Please come forward and state your agency name. Good morning.
Good morning. I am from the Patient Rights Advocate Organization, and my name is Marie LaRobe-Deer. I'm a research analyst for PRA, and I am in support of this. We need all the support we can get to bring hospital compliance per the federal regulation, which has been in effect for at least, since January 2020, I believe, yeah. So it's been in effect for a couple of years, and we haven't really seen compliance. My specific role is looking at the hospital files themselves, so I stare at hundreds of files, and we just finished a report including Virginia, and Virginia did not do fare well, which reflects what you said already. And patients really need support and be able to see prices up front. They need these files to be machine readable, truly machine readable, so that they can be used to provide the information to patients to see prices up front so they can budget. Many people have high deductibles, and if they know what a procedure costs and they can compare prices between facilities, they can, maybe save, and we can maybe reduce medical debt, which is rampant. 1 in 5 Americans. So your support is really needed. I look at these files and there's no standardization. They're very difficult to, they almost need decoding versus just coding to provide, let's say, apps from machine readable files to provide to patients. And I believe that was the initial intent of machine readable files. So I am in full support of this, and I believe that the patients need some mechanism to protect themselves. And if we have this enforcement of this regulation, and especially with the additional efforts that Virginia is doing, then hopefully patients will see what they're, will see real prices and be able to protect themselves if they're overbilled and sued. It's adding an illness onto an illness, so that with the stress level. So I believe that's it.
Thank you
very much.
Thank you. All right, anyone else in the audience in support? I do have some in the queue that are in support, but I'll go to them last. So anyone in the room in opposition, 2435?
Good morning, Mr. Chair, members of the committee.
Good morning.
Brent Rawlings for the Virginia Hospital and Healthcare Association. We do oppose the legislation. We've had a number of conversations with Delegate Hodges on this topic and acknowledge that we've been moving in the right direction, but still have some problems with this approach overall. As was referenced previously, we're talking about a state law that has not even gone into effect, and here we are changing it, adding new mechanisms and penalties and approaches. And I'll get to some existing penalties and some clarification on what CMS does in this area. I did want to respond to a couple of the comments about outpatient surgical hospitals not being in compliance. I think that's probably accurate. Based on the work group that was done this summer, we found out, based on interpretation of federal and state law, that ambulatory surgery centers are included in this price transparency requirement, but that being distinguished from an inpatient hospital. As far as we can tell, and we've done this on VHHA's own website, we've posted the machine-readable files voluntarily on a website. They're available for the public. So those files are out there. There seems to be some disagreement about what compliance means, and we saw that in the work group on this very topic over the summer. When we looked at some of those files and heard from some of the groups that have a different opinion about what compliance means, we found that their determination is a little different than what CMS's is. And we've maintained from day one that the ultimate authority on this federal law and compliance should be CMS, and that agency determines it alone. Delegate Hodges did mention that this does leave that ultimate determination with CMS. Haven't seen the substitute yet, but that is a positive aspect. How that actually plays out, a little unclear. With respect to CMS, just wanted to point out, there's been reference that there's actually been 2 hospitals that have been fined. And I want to point out that there's maybe a reason why only 2 hospitals have been fined, because fines can only be assessed, and I'm looking at the CMS frequently asked questions about compliance, and when there's a material violation, may assess on a hospital civil monetary penalty and publicize the penalty on a CMS website should the hospital fail to respond to CMS requests to submit or comply with the requirements of a corrective action plan. So the fact that there aren't fines and penalties does not mean that there is not work being done by the federal government. Every one of our members in some way or form has received communication from CMS about the need to comply. Some of them have received letters of noncompliance, and those are working through the process. So in the short 2 years that this law, a major regulatory change has gone into effect, we have seen quite a big improvement. With respect to CMS and the civil monetary penalties, I guess the question we have with this legislation in the first place is, how big of a stick do you need? The civil monetary penalties, and as was referenced before, this would get referred to CMS. And so if there is noncompliance, civil monetary penalties for a hospital with 30 or fewer beds for a year of noncompliance equates to $109,500 a year. For hospitals with 31 to 550 beds, a fine of between $113,000, $150,000 to $2,007,500, and for an over 550 bed hospital, over $2 million per year fine. That's a pretty big stick for a regulatory requirement. We would submit that that is sufficient. A couple of things now, speaking directly to the bill. We can understand the need for a directed plan of correction by VDH. We can understand reporting to CMS. We think that's an appropriate approach. We can understand Consumer Protection Act. The one thing we cannot get behind for sure is the language in here that would prohibit the right to collect from a patient when there's noncompliance. As with another measure before this body that will come before this body later that has a civil right of action, acknowledge that this is better than a civil right of action, but what it still means is for any period of noncompliance, there could be no collection of payment for any services provided by the hospital during that period. And that has a pretty significant impact, especially when you consider that there really wouldn't be any requirement of intent, showing of harm to the patient, any showing that the patient relied on that hospital pricing information, or any misrepresentation by the hospital. So we continue to believe that even though it is slightly better than another approach that has been proposed, that prohibiting a hospital from collecting for services where there's no dispute as to whether or not those services were provided in good faith, had the intended outcome, or that there was even any dispute over the bill could not be collected is highly problematic. And we submit that, again, this is far further than we need to go to ensure compliance on a law that we've already demonstrated good progress in achieving. So I thank you for listening.
I thank you, and I'll just, in the interest of time, I guess you all know, if you have anything new to add to his testimony, please do so. If not, just state your agency name and your position, please.
Thank you, Mr. Chairman. Good morning. Michael Forehand with the Nova Health System. I echo the comments of Mr. Rawlings and just know that we are compliant with federal price transparency rules.
Thank you.
Good morning, Mr. Chairman. Tom Prevet, representing Centra Health in Lynchburg, Virginia. We have thought, I think Delegate Hodges' comments have been very helpful, but we are not there as yet in terms of the concerns that we still have, and we oppose the bill.
Thank you.
Good morning, Mr. Chairman, members of the subcommittee. Mark Hickman on behalf of VCU Health. We associate ourselves with the remarks of Mr. Rawlings, and we have always worked hard to meet the robust federal requirements. We want to point out that we have received feedback from CMS, and believe we are in compliance with the requirements. And we also have a user-friendly price estimator tool online and by phone, which takes into account health insurance information as well. So we oppose the bill. Thank you.
Thank you.
Good morning, Maura Holdren with Bonsecore Health, Virginia, and we oppose the bill for the reasons stated previously. Thanks.
Thank you.
Good morning, Mr. Chair, members of the subcommittee. Emily Reynolds on behalf of the Prince William Chamber and Greater Williamsburg Chamber, and we oppose this bill on behalf of our hospital members. Thanks so much.
Thank you.
Good morning, Mr. Chair, members of the committee. Kristen Burhop from the Virginia Chamber of Commerce, and for the same reasons stated, we oppose the bill.
Thank you.
Morning, Mr. Chairman. Scott Johnson speaking on behalf of HCA Hospitals. HCA strives to comply with the federal requirements and always has. To give you something new, you heard some references to outside groups, and they are applying different methodologies. A quote from CMS that was published in August: "The Centers for Medicaid and Medicaid Services, which administers the law, defends its enforcement and said outside estimates on hospital compliance vary widely because they apply different methodology. So be careful when you deviate from CMS standards." Thank you.
Thank you.
Good morning, Mr. Chairman, members of the committee. Mark Lawrence with Carilion Clinic in Roanoke. We would ask you to oppose the bill. We are in compliance with the federal statute. Thank you.
Thank you.
Mr. Chairman, Chris Nolan on behalf of Ballot Health, also in compliance with the federal requirements. And just to point out, the two hospitals that were referenced earlier that were fined were not Virginia hospitals. Thank you.
Thank you.
Good morning, Mr. Chairman. Keenan Caldwell on behalf of Centera Healthcare. We are 100% in compliance. We oppose the bill. My friend.
Mr. Chairman, Curtis
you.
Bird, Chesapeake Regional Healthcare. We too are in compliance. We oppose this bill, and I'm aware of at least one individual who reached out to the hospital to compliment us on how easy it was to navigate our website for the information they were looking for. Thank you.
Thank you.
Good morning, Mr. Chairman. Mark Duncan with Riverside Health System. We are in compliance as well. It pains me to say it out of deep respect for the bill's patron, but we continue to have reservations about the bill. Thank you.
Good morning, Mr. Chairman. Randy Pearson on behalf of Augusta Health. I'll echo the comments you have heard previously and say we oppose the bill. Thank you.
Thank you. Okay. We have some witnesses in the queue, but in essence of time, I'm going to just recognize them, and if they are not in support, as they have indicated, they just can correct me. But we have Mr. Jeffrey Hanna, and let's see, he's a private citizen. We have Mrs. Marnie Carey, Power to the Patients. We have Dr. James Tinsley, Lighthouse Direct Primary Care Center for Health and Cancer. Mr. Keith Berger, Prevention PC, and Ms. Vic Nichols, whom we heard before. And they are all registering support of the bill. So with that, I think we need to move on. We've got a pretty heavy docket this morning, so committee works on motions.
Mr. Chairman, can I just have a
Delegate Hodges,
quick
sure.
last word? Thank you, Mr. Chairman.
Yeah.
And I appreciate everyone coming forward and visiting my office to discuss this legislation. Bipartisan legislation that was passed because the federal government is not enforcing this. So, of course, we went ahead and conformed with federal law, but we still need some teeth. And I appreciate those folks that were here today that says they're in compliance, but it's the ones that are not in compliance that we're looking at. And it was mentioned that, deviating from the federal standards, that's why it's important for VDH to report to CMS, because you have that conduit there and that discussion between VDH and CMS. And all we're saying here is if the facility is non-compliant, then they cannot seek debt collections against the patients. And that's the important part of the bill. So it needs a little bit of teeth moving forward so we can bring those folks, into compliance and protect our patients. So thank you, Mr. Chairman.
Mr. Chairman, I have a motion.
Delegate Robinson.
I move that we gently lay the substitute on the table.
Second. I have a motion and a second to lay on the table that's non-debatable at this point. Delegate Ferris, do you have anything to add? Okay. All right. All in favor, vote, and please vote on your voting board, please. Motion to lay on table. Motion to lay on the table passes by a vote of 9-0.
Thank you, Mr. Chairman.
Thank you, Delegate Hodges. Okay. We knew that would have a little time with it, so let's go ahead. Any other patrons in the room? I see Delegate Tran. Delegate Tran, would you like to? Oh, I'm sorry. Okay. Everybody spread out. Sorry. Good morning.
Good morning, Delegate Edmonds. Before you is House Bill 2219, and I am going to ask that you lay this bill very, very gently on the table, but I wanted to explain why I think it's important in the conversation I had with you, Mr. Chair, and the Uber Chairman as well. As we know, so much of in our daily lives, we are capturing so much of our health data through our wearable technology, such as our smartwatches and other physical trackers, as well as through applications online where we are inputting information perhaps about the medication we take, about the steps we take, about our weight, how we're feeling emotionally and mentally, and more. And so that data, this online health data, is not protected anywhere at the federal level, nor is it protected in the Virginia State Code. This January, the Consumer Data Protection Act went into effect. And if you look at that act, all the information and referrals to health data actually links back to the section of the code. It's the Health Records Protection Act. And the Health Records Protection Act, which is our own state HIPAA law, doesn't discuss what we do with online health data. So this bill was an attempt at helping to suss out how we protect that data by expanding HIPAA. And I know that, I hope it's the start of a good conversation in talking with data privacy experts, with patient advocates. This is probably like the cutting edge of policy work and an emerging area of policy work that needs to be really examined. And so I hope that you lay it gently on the table. And the Uber chair has said that he'll write a note to the Joint Commission on Healthcare to take a look at this issue.
Thank you, Delegate Tran, and I think definitely appreciate you bringing the issue to the committee, and hopefully we can get something satisfied on this issue in the near future. So with that, is there a motion to lay
on the table?
Motion lay on the table and seconded. No debate. I'll vote on the board, please. Thank you, Delegate Tran.
Thank you, Mr. Chair. And just I want to thank Council Yates for working with us on a pretty complicated bill. Thank you.
Okay, next we'll have Delegate Rome. Good morning.
Thank you, Mr. Chairman, to the members of the subcommittee. I got two bills. They should both be pretty quick. HB 2029, we'll start off with that one first. So this consists of technical amendments as requested by the Public Guardian and Conservator Advisory Board. That's PGCAB. First, we seek to clean up the language regarding the terms of service of these board members. The bill equalizes the terms for all members of the advisory board for 4 years, which is in line with other DARS advocacy boards, that's the Department of Aging and Rehabilitative Services, and shifting the current mix of 3 and 4 year terms that are assigned arbitrarily and result in 2-tier membership structure. The second change would strike outdated language to align the code with current practice. When the section was drafted in 1998, it was envisioned that public guardianship programs would have to notify courts when they reached maximum caseload, so courts would not refer additional clients when the program was beyond capacity, but in practice, the process for adding new clients comes from the programs themselves, not from the court. If an agency or provider believes there is a need for a guardian, they can contact the program to submit a request, and the program, working with its multidisciplinary panel and with DARS, determines whether it can accept the case. Only following that is a petition filed in the court. And finally, a plan to notify the sheriffs and circuit court of potentially being out of compliance with the required staffing ratio is unneeded, confusing, and would impose an unreasonable burden on the public guardianship program providers who are serving multiple jurisdictions.
Thank you, Delegate Rome. Anyone have any questions on?
And I'll also note that there's someone from the board who's going to testify online.
Okay. All right, anyone in the audience in support of House Bill 2029, please come forward and state your agency and name.
Good morning, Mr. Chairman. Jared Calfee with AARP Virginia as a simple administrative cleanup, and we support the bill.
Thank you. Anyone else in support? Anyone?
Online, there's Erica Wood.
Okay, I'll take online testimony after room testimony. Anyone in the audience in opposition to 2029? All right, we'll go to the queue, and we have Ms. Tatus.
Morning again. So at first, when I read this, I had to go back and, I was under the impression that we were discussing CPS and the guardianship. And I was at first in favor because I was reading this as the removal of safety plans, which targets children and parents. But then when I went back to read it, this seems to be a problem across the Commonwealth, is that the burden and that we're removing safeguards for whether it's children or adults in this case for an undue burden, is that in this case the burden to protect them, and you have stricken through when the program falls below or exceeds ideal range of staff, that you're no longer going to consult with the local circuit court or sheriffs. That seems to be when a program falls below. That would be, to me, something that you would not strike out if you're actually a patient advocate, or in this case, someone who needs a guardian or conservator, or even an adult with incapacitated abilities. But more importantly, the children, is that lowering the standards for how we care for people who need these helps is not because of a burden. We need to look at a different angle of this and how we get them more appropriate programs and more appropriate help, whether it's budgeting or however you do, instead of dropping the standards or the requirements because it puts an undue burden on somebody else. Thank you.
Thank you, Ms. Tatus. And Erica Wood, are you in the room?
Yes, hi. Yes, I'm a member of the Public Guardian and Conservator Advisory Board, and this simply makes two technical changes in the Public Guardianship Code section, and that is concerning adults, and both are non-controversial. They derive directly from board recommendations. What this does is it doesn't change anything substantively. The process works very smoothly with all due safeguards. It simply removes the outdated wording on advance notification, because that all happens. It derives from the programs themselves. And when they have the capacity to accept the case, then there will be a petition to the court.
Thank you, Mrs. Wood. Okay. Any other questions, committee? Committee operates on motions. Have a motion to report and a second. Any discussion? Hearing none, please vote on your boards. Motion to report passes on a vote of 6-3. Thank you, Delegate Rome.
All right, thank you, Mr. Chairman. And so, Mr. Chairman, second one on this is HB 2437. I'll note there's a committee substitute that's going to be reported by council, and I'm happy to explain what's different in the substitute versus the original introduced bill.
Move the substitute.
Is there a second? Second on the substitute? Any discussion? All in favor say aye. Aye. Opposed, no. The substitute's before us. Delegate Rome.
All right, thank you, Mr. Chairman. So first, the difference is in line 13. We added the words, and other guardians appointed pursuant to Chapter 20 of 64.2-2000. And then on line 93, we added the phrase pursuant to 64.2-2019 after the word guardians. So that phrase, that section now reads, the department shall develop and provide training for guardians pursuant to section 64.2-2019, which shall include training on the responsibilities and duties of guardians, how to complete annual guardianship reports, how to involve and encourage participation of incapacitated adults in decisions made by such guardians, medical advocacy, and decision-making on behalf of other persons. So, Mr. Chair, HB 2437, this is in accordance with JLARC's recommendations 18, 19, and 21. from their 2021 report regarding how to reform guardianship in Virginia. This establishes a training program for court-appointed guardians throughout the Commonwealth. No more than once every 36 months, guardians will be subject to complete the training program developed by the Department of Aging and Rehabilitative Services. Guardians will initially be required to complete this training within 4 months of the date of entry of the court appointment. This program will include the responsibilities and duties of guardians, how to complete annual guardianship reports, how to involve and encourage participation of incapacitated adults in decisions made by such guardians, medical advocacy, and decision-making on behalf of other persons. All guardians are currently required to file an annual report with their local Department of Social Services in order to ensure oversight and confirm that guardians complete the training. This bill will slightly amend the report to include a statement from the guardian on their training status. And the Department of Aging and Rehabilitative Services will then develop and implement the training program and annual report amendments by July 1st of next year in 2024, so they got some extra time. And guardians appointed prior to July 1st of 2024 shall complete the training before January 21st, 2026. I'll also note on this bill that Delegate Kriesik is the one carrying the budget amendment on it.
Thank you, Delegate Rome. Okay, anyone on the committee have any questions?
And Mr. Chairman, I'll also note that Tracy Smith from JLARC is here to answer any questions if you have on technical nature.
Okay, thank you, Delegate Rome. All right, anyone in the audience like to speak in favor of House Bill 2437, please come forward and briefly, if you would, please state your name and agency.
John Smith with the Disability Law Center of Virginia. Mr. Chairman, members of the committee, we're in support of the bill. As you know, guardians are entrusted with great responsibility to make decisions on behalf of other persons. This modest training, we think, is reasonable in light of that responsibility.
Thank you.
Good morning, Emily Hardy with Virginia Poverty Law Center. For the reasons already stated, we support this bill. Thank you.
Thank you.
Good morning. Jared Calfee with AARP Virginia, and for the reasons stated, we also support the bill.
Thank you. Anyone in the audience in opposition? In the queue, we have, let's see, Ms. Tatus. Again, if you could be brief in the queue, we've still got a few bills left.
Yes, good morning. I will be brief. I am in support of this. And I would also urge everybody to, since we're talking about adults, to maybe next go around, look and see, you can more than welcome to seek me out, and let's put these same protections on children when it comes to CPS and foster care.
Thank you. Ms. Wood? I think you're muted, Ms. Wood.
Okay, hope you can hear me now. This time, I'm Erica Wood again, this time representing the Northern Virginia Aging Network, for which guardian training is one of its 2023 priorities, and I support the bill.
Thank you, Ms. Wood. And Ms. Tanya Milling? Okay, not in the room. She has registered support in favor of. All right, if this bill is favorably reported, it would need to also be referred to appropriations.
And Mr. Chair, I believe the correct motion, if that is to happen, is to report the substitute to purpose.
Thank you. Okay. All right, we have a motion to report the substitute and refer to appropriations. And a second. So, any discussion? Hearing none, vote on your boards, please. Motion to report and refer passes on a vote of 8-1. Thank you, Delegate Rome. Delegate Munden King, good morning.
Thank you, Mr. Chair, members of the committee. Good morning. So House Bill 2085 is one of 4 pieces of legislation I've introduced this session to help thousands of Virginians suffering with sickle cell anemia. Sickle cell anemia is an extremely painful disease that thousands of Virginians are suffering with. In sickle cell patients, pain develops when sickle cell-shaped blood vessels get stuck in your vessels in your chest, abdomen, joints, and bones. The pain can last for a few hours up to a few weeks. Women experiencing sickle cell anemia have described the pain as worse than childbirth. So this much-needed bill is to help patients gain more access to medicines that help with the pain. And why it's needed, in an FDA study, It explained that patients are often treated like drug seekers, that hospitals don't understand their pain. They say that they are faking it, and this results in inadequate treatment and more suffering. And in communities like mine, we're very fortunate to have great access to hematology, but hospitals and emergency care that is capable of supporting patients with sickle cell can be 20 to 30 miles or more away. And in rural parts of Virginia, that is even further. So you have people suffering and in need of help. And the reason that I know this is because my family suffers with sickle cell anemia. And I know many of you missed me last year for about a week when I was away from session while my child was hospitalized with a pain crisis. And what we know is that sickle cell is a painful, deadly disease. And this bill makes it a little easier for those suffering to get access to medicine. And what it will do is add sickle cell to those conditions such as cancer and heart disease that are included in the palliative care section of the code, and this will add sickle cell to that section. Thank you, Mr.
Thank you,
Chair.
Delegate London King. Any questions? Okay, we'll go to the audience. Anyone in support? House Bill 2085, please come forward. Anyone? Delegate Waxman, you have a question?
Yes, I'm sorry. I couldn't skip my button fast enough, Mr. Chair. I had a question for the delegate. As far as reporting to the PMP program, that was a patient safety aspect where prescribers and dispensers can go in to look at these records to make sure that the patient's not getting overly medicated, that the morphine milliequivalent rate's not too high. Also, I can see where it would be beneficial for somebody treating somebody with sickle cell with that one website. They can determine how often they're getting their narcotics filled to see if they're under therapy, over therapy. I just question why we're removing that patient safety from this one disorder when there are multiple other disorders that are similar in pain scale.
Sure. Mr. Chair?
Yeah, Delegate London King.
So I would say to the delegate, just like cancer and different heart diseases, sickle cell treatment is an ongoing treatment that doctors and patients work very closely with. I mean, I'm on the phone with my daughter's doctor maybe every other week, and so the doctor is managing it, and so they know what their patients need, and this would create more access to that. And as for patient safety, I definitely understand that, which is why, the doctor and patient relationship is so important, just like it is for cancer, which is an ongoing treatment, and heart disease. So this would just add that because they are seeing a doctor so regularly as opposed to someone who has an injury or another reason for needing the medicine.
All right, the committee queue is filling up pretty quickly, but let's take any comments in opposition at this point in the audience before we have questions from committee.
Let's see. Clark Barron with the Medical Society of Virginia. We had good conversations with the delegate. Just to be clear about what the bill does, it adds sickle cell to the list of diseases or cutouts that don't need to be reported to the PMP. And physicians and all providers would want to know what drugs have been prescribed to people. That is the point of the PMP. The current opioid regs that we negotiated several years ago do have a carve-out for sickle cell and other extremely painful diseases. We've talked to the delegate, and we're happy to work with her on how we can improve those regulations and have those conversations. But for now, as is, more information is better than less information when it comes to these drugs, and so we unfortunately have to oppose the bill. Thank you.
Thank
Mr.
you.
Chairman.
Delegate.
Could I ask a question of Clark?
Clark.
Yes, sir.
Clark, is there anything about the current reporting requirement that prevents a patient from getting the medications they would need?
Not to my knowledge, no, sir.
Mr. Chairman.
Delegate Price.
Yes, Clark, can I ask a question, please?
Yeah, there's no elegant way to do that.
Thank you. So I do definitely understand that this would not in essence, prevent someone from getting the treatment that they need. Does the PMP have the condition listed or just the medications?
I don't know that off the top of my head, if I'm being honest.
Okay, so I'll get my answer to that from someone else.
Yeah, I'll defer.
But can the information...
Aaron has moved closer to the microphone.
Thank
so
you.
She can answer questions.
Can the information from the PMP, even though it was created to be a safety protocol, can it be used as a discriminatory tool as well?
I wouldn't know that.
Mr. Chair?
Let's see. I'm not sure. Let's hear a little more testimony before we have questions, because it may answer questions. So, anyone else in opposition to House Bill 2085 in the room? Okay, and in the queue we have Ms. Tatus again.
Morning. Yes, it's me again. I'm speaking to you as a survivor of the opioid crisis. I have been clean for 15 years now, and this was extremely alarming to me when I first pulled it up, because the PMP requires a plan for 7 days or more. So to add a specific, prescribers shall not be required to meet the provisions of subsection B, which is the PMP, and it lists hospice or palliative care. So it's not just cancer, it is patients dying of cancer, which is extremely different than somebody suffering with sickle cell anemia. They are functioning in society. My daughter, since the age of 4, has had rheumatoid arthritis all over her body. So are we going to add her in there? No, we would not. Then it goes on to say it has other opioid is prescribed to a patient in a nursing home or assisted living that uses a sole source pharmacy. There are very specific provisions. So to add the very broad opioid is, again, they will be exempt from the PMP strictly if they have sickle cell anemia. It is too broad. And I understand that this is in sickle cell anemia, let's just be clear, it is an African-American disease. And so recovering from 15 years of being an addict during the opioid crisis, when pain medication was doled out like candy, to give this opening to the without any stipulation, just saying that they are exempt from all of this is extremely alarming. And I would wonder why somebody as an advocate for your community would want to open a door this broadly when we know how widely opiates are abused. So I just wanted to point out what the legislation actually says is it is in specific regard to opiates only.
Thank you. Okay. We have Delegate Cherry.
My question was answered by a prior speaker, so I'll yield my time back.
Okay. Delegate Price.
Yes, thank you. So it may not have been Clark that had the answer, but is there anyone present that could tell me more about the PMP and what's included in the information?
I'll be glad to.
Sorry about that, Clark. I didn't mean that.
Good morning, Mr. Chair. Erin Barrett on behalf of the Department of Health Professions in the Prescription Monitoring Program. The diagnosis is not included as part of the PMP when a prescriber gets a readout, when they check the PMP to see what's been prescribed. It will say the prescriber, the patient, the medication, and the dosage, and the date. I think it is important to note in this bill, however, that the exemption of C, where sickle cell anemia is being exempted, it exempts the prescriber from checking the PMP prior to prescribing opioids. It does not have anything to do with reporting to the PMP. Subsection B talks about checking prior to prescription. I think there has been some discussion here today in support and in opposition that talk about exempting it from checking. And I would also like to note that under the opioid and buprenorphine regulations that are part of a lot of Department of Health Professions boards, sickle cell anemia is exempted from those regulations. And Mr. Chair, I'm happy to answer any more questions.
Delegate Price, did that answer your question?
Yes, Mr. Chairman, and I would like to speak to the bill at the appropriate time.
Go ahead now.
Okay, thank you. I was here for a lot of the conversation when we got to the 7 days, and there was negotiation to get to that 7 days. And I remember then that there was an advocate asking for sickle cell anemia to be addressed in a different way because of the nature of the disease. They listed the impact that chronic pain can have on mental health and physical health, and that a lot of patients, not all patients, from what I understand, not all patients with sickle cell are Black, but there were some Black patients that were being discriminated against and assumed that they were being drug seekers as opposed to seeking treatment for their disease. In a 2016 report, it showed that there were physicians that believed that African Americans were experiencing pain differently. And that adds to the culture of what I have even experienced when I'm trying to get medicine for a chronic condition. And I think that this is an amazing bill that should have been done when we did the original bill for the 7 days that allows for people that need the treatment to get it when they need it. And fights back against honestly, some of the systemic racism that is still within our healthcare system. So I would move that we report the bill.
Let's hear from Delegate Adams. You have a question.
Thank you, Mr. Chair. Speaking to the bill.
Delegate Adams.
You know, it's frustrating to try to discuss real-world situations in a committee of people that really wouldn't know. The reality is that sickle cell is an exceedingly painful disorder. This bill does not mandate the treatment before the provider. What it does is afford them an option, which is one of the main unintended consequences of how we have dealt with the opioid addiction problem. People are suffering, and they're being not provided the only medication that can alleviate that suffering out of fear for breaking the law or overprescribing or causing a long-term complication. What I can tell you is, not having sickle cell, but having chronic pain and understanding chronic pain very intimately, it affects every aspect of your life all of the time. The fact that providers are no longer listening to patients and treating their pain appropriately out of fear is horrendous for our society and for people in general. And as difficult as it is to hear, there is systemic racism in the healthcare system. I've seen it myself. You know, there is already a mentality amongst healthcare providers, especially in acute care, that people who want or request narcotics are drug seekers. That can be true. It's often not true. Now, if you add color as another factor of that human seeking drugs, that does ramp up the narrative that this is a problem person. And you would not know that if you were not practicing in these areas. But that is what I have done my entire life. I've seen it over and over and over again. Sickle cell is just one of these carve-outs. So is cancer, but so is pain related to dialysis. I mean, we really have to give providers the option. It doesn't mandate anything. It allows providers to practice medicine, and putting things in the law that takes away from that is harmful to patients. Thank you, Mr. Chair.
Thank you, Delegate Adams. Delegate Radcliffe, did you have a question? You were in the queue at one point.
I was earlier going to answer the question about the PMP. As somebody who reports to and queries the PMP, it does not include diagnosis. It includes very much what the person from the, I guess it was VDH, indicated.
Thank you. We do have a motion to report and a second. So any further discussion? Hearing none, vote on your boards, please. Motion to report fails in a vote of 5-4.
Thank you, Mr. Chair, and thank you to the members of the committee. I want to say thank you because right now there are sickle cell patients watching this, and so often they have been ignored and felt invisible. So to even have this conversation today, even though this bill didn't go in the way we would like, is so important because we are not functioning. We are bedridden, we are in pain, and we are dying at alarming rates. So I just want to say thank you for hearing us and seeing us and taking the time to discuss today. Thank you.
Thank you for advocating. All right, next we have House Bill 2018, Delegate Adams. Good morning.
Good morning. Thank you, Mr. Chairman, members of the committee. I appreciate you taking up this bill today. This is a proposed amendment to the Children's Services Act, in particular, a small expansion of the confidentiality requirements related to information that can be shared at family assessment and planning teams and community policy and management teams. And specifically, I'll tell you how I came to present this legislation. It followed a conversation I had with my local sheriff, who I think in the wake of one of these horrific school shootings alerted me to the very tight confidentiality rules that these teams are under. And he mentioned that it would be useful if he, on occasion, could share the information with, say, a school resource officer about someone who is showing imminent risk threat to themselves or to others, or other people within the school system, to put them on alert to avoid something terrible happening. Otherwise, this information is to be kept confidential. And of course, that is to protect the privacy rights of the children who are being serviced. But I present this to you as what I think is a reasonable balancing of the public safety concerns that we, of course, all share. I believe that my sheriff is online to testify in favor of this proposal, and I would ask that you hear him, and happy to answer any additional questions.
Thank you, Delegate Adams. We certainly will in a moment. Delegate Price, did you have a question?
Yes, I had a question. And this may be for the delegate or anyone else in the room, but what is the current process for mandated reporters, and who do they report to? Because I believe that there is an instance where there are people in the building that are trying to know what to do in the instance of a crisis. So do you know who the mandated reporters are and who they report to?
Mr. Chairman, Delegate Price, I think the proposal that I'm dealing with is allowing the information, not at the moment of an instance or a public crisis, but allowing the information that's learned from the individuals at these meetings who are servicing the children to be able to, in terms of a preventative effort of sharing information with others. I have to defer to staff about, in-time reporting.
Can I
Delegate Price?
So, I'm sorry, let me ask a different way. If these people were to find out through, doing their jobs in a wonderful way that there was a threat, right now, is there no one else in the school building that they can tell, not the principal, not the school counselor? There's no one else they can tell. They just have to hold that information to themselves? Or is there someone that they are supposed to report to?
Well, I'll certainly defer to someone who has more expertise on this about whether there's any other provisions that govern, but this particular provision, the code section says all information, the way it currently reads, all information about specific children and families obtained by the team members in the discharge of their responsibilities to the team shall be confidential. And so my proposed language is just to add a provision right after that. However, if the team members obtain information from which the team determines that a child poses a threat of violence or physical harm to himself or others, the team may share such information with local law enforcement or the applicable threat assessment team that is established pursuant to another section in the code.
I think we may probably get some clarification from Sheriff Taylor in a moment on that too. So, anyone in the audience like to speak in favor of House Bill 2018? Please come forward and state your agency name. Good morning.
Good morning, Mr. Chairman, members of the committee. Ariel McAloon, representing Fairfax County government, and we support the bill, thinking that it would help with allowing the members of both the FAPT and the CMPMT share information when they deem appropriate.
Thank you. Question, Delegate Guzman? Could we have someone close that door back there? Okay, that's good.
Ma'am, the person from Fairfax County government, could you come to the podium? I just need to ask a follow-up question. Thank you. Which department do you represent? Fairfax County government, a special agency?
Fairfax County government.
Which agency?
Not a specific agency, just the county overall.
You're an employee or a lobbyist? I'm sorry.
Yes, lobbyist for the county.
Mm-hmm. So follow-up question. The FAP team, usually when they get together is to determine the funding that is going to be used for children at youth. So for the child to be determined that the child is at risk, it goes to different stages, right? It could come through the foster care system. It could come, different ways. So how do you, because I've been part of those meetings, and, when the child, it's going to be, what we are discussing during the FAP teams, it's going to be funding from CSA and how we're going to help this child. So how do you think, what conversations do you envision, discuss that should be shared with the sheriff? Could you give me some examples? Because I'm trying to think myself about one, because there are different stages when a child could be named at risk.
I think we probably could hear, maybe Sheriff Taylor could, in the queue, could help answer some of these questions.
Thank you.
Sheriff Taylor, good morning. Could you?
Good morning, Mr. Chairman. Good morning, Mr. Chairman, and thank you for your time. Just a little bit about the process. When we have our CPMT meetings and we have the approved agenda, they're in open discussion and the public can attend. Once we start discussing specifics about the whole host of needs by the children, we go into closed session. And we hear reports from the evaluators, we hear reports from the vendors who support our children, and we hear about children that may have concepts, forming concepts of homicidal ideations, suicidal ideations, and they are in strict confidence. So all of those discussions are held in closed sessions. Once we approve the invoices and we have our discussions about maybe a specific individual, we come out of closed session and we vote to pay the invoices, and that's part of our governance on the CPMT board. But the issue, the public safety issue, I believe that comes from this, sometimes in our locality, I may know about particular instances, let's say that happens at a school setting, because it's reported to our school resource officers. I may recognize that name at the CPMT meetings. What the school resource officers do not know and cannot be told because of the strict confidentiality aspect is how this child may or may not be progressing. And if they're in a school setting, it would be important for our SROs that are protecting staff and children to know these things. And I cannot share that information without violating the confidentiality and state statute. So I appreciate Delegate Adams for bringing this to the floor and to the committee because it does create a conflict And our whole goal is to make our schools, especially our school campuses, safe as we possibly can.
Thank you, Sheriff Taylor. All right. Anyone in the audience, anyone else in the audience in support? Anyone in the audience in opposition? All right. Continuing in the queue, we have Mr. Greg Skall. Is that correct? Skall?
That is correct. However, Mr. Chairman, thank you for recognizing me. I am here for HB 2008, and apparently there was some confusion with scheduling me. So,
Mr. Skall, 2008 or 18?
HB 2008.
Okay, this is 2018. I'm sorry.
Yes, and I apologize for the confusion, but apparently I got scheduled to speak for both bills, and I'm really only here for 2008.
Okay. All right. Then next we'll hear from Ms. Tatus.
Morning, and again, this is my last one, I promise. My question would be how this would impact the disciplinary practices where principals cannot or are not allowed to report to law enforcement if there is no actual physical harm. So there is no requirement. It's actually been debated the last couple of years, and unless there is physical harm done, principals are not required to notify law enforcement. So the two seem to be in opposition of each other because they would impact each other. And also is that what's going on in public schools. So Virginia was the first state to mandate threat assessment teams in 2013, nationally. So that those teams, that requires threat assessment software. That would be Gaggle, GoGuardian, Securely, Bark are the four big ones. I've spoken with Elizabeth Warren's office. They are in opposition. So you have people being paid $10 an hour to sit at home and monitor everything these children do under whether you want to call it threat assessment or not. You've got threat assessment teams evaluating these children. You have unqualified teachers filling out behavior screeners on these children. And so to add another layer of reporting these children, and keep in mind that Virginia being one of the only states that has very little or no textbooks, everything in the computers that they're doing, including this, is considered a survey. And so under the Library of Virginia, if you look up the Children's Services Act, it's specifically, or threat assessment, this data is kept post-graduation for 75 years. And so everything that these children are doing that you report, you are creating a generational problem that we have no clue how this is going to manifest on children. So are we adding and not addressing the problem correctly? I 100%. And so it's hard to be in opposition, but also, again, is that we have to, the disciplinary is a huge question to me. How would this impact the legislation people have debated about whether principals, what are the requirements for contacting law enforcement if it's only physical harm? In Chesterfield County here last week, a student threatened to kill another student, and nothing was done. So there is a systemic problem, and if we're only going to focus on this one part, we have to look at what's already being collected on these children, and if we are adding to the problem or if we are actually looking to fix it. And because adding another layer of data release on these children, when the right of conscience has to be acknowledged, and that privacy and are these people qualified to report would be a huge question for me. Thank you.
Thank you. Okay, Delegate Price.
Yes, Mr. Chairman, I'm not sure if it's a question or a statement, but I'm concerned about specifically the harm to self portion, because it would seem that the law enforcement officer may not be the best trained as opposed to a mental health professional. So in that instance, what would the process be if the law enforcement person on the campus was the one that was flagged for self-harm? How can we, a lot of work that we did with the Behavioral Health Commission and the Behavioral Health Sub was to decriminalize mental health issues. So would this be going backwards? How do you envision that the law enforcement officer would be the one that needed to know that information?
Delegate Adams.
Well, Mr. Chair, I would just say, nothing in this proposal deals with any criminal penalty, and nor to the prior statements that were made does it amend in any way, the law that exists with respect to the threat assessment team. This is just taking the confidentiality provisions, opening that up a little bit to share information to those for whom it would be relevant to protect the public safety of others, and in a very limited way.
Thank you. I think Delegate Adams, I think it saved lives. So, okay. What the committee works on motions?
Move to report.
Motion to report and second. Any further discussion? All in favor to report, please vote on the boards. Motion to report passes on a vote of 5-4. Thank you, Delegate Adams.
All right, thank you, Mr. Chair.
And lastly, but not leastly, Delegate Sickles. Good morning. House Bill 2173.
Good morning, Mr. Chair, members of the subcommittee. This bill is a request from the Health Department about a deregulatory nature with regard to antique furniture. Just as background, the Department of Health regulates dealers of secondhand bedding, upholstered furniture, including durable medical equipment and items designed for infants and children, requiring those items to be sanitized before sale or rental to the public. Examples of regulated items include car seats, strollers, couches, mattresses, pillows, rental wheelchairs or home hospice beds, and upholstered chairs. Sanitation reduces the level of pathogens on the surface of secondhand items and kills bed bugs in their eggs. Sanitation is usually accomplished through application of isopropyl alcohol-based spray and requires a sanitizer permit. But in 2019, the Attorney General's office determined that the Board of Health did not have the authority to exempt antiques from the regulation as included in the regulation at the time. And the departments are completing a regulatory action on this, and this is what will happen if we don't pass this little exemption bill. And there's experts here, I assume, to talk about this in more depth. I know this is an arcane issue. This is so any person. This is what will happen if we don't pass the bill. Any person wishing to sell, rent, or otherwise commercially dispose of antique bedding or upholstered furniture will be required to sanitize the item before sale, obtain a sanitizer permit from VDH. The fee for a sanitizer permit is $60. Antique dealers will also incur starting costs of $40 to $150 for sanitation supplies. The VDH will incur indeterminate but significant costs associated with inspection and regulation of antique dealers. So this bill is a simple line to exempt antiques, which the definition was 75 years old. That is all it does, and I assume there are people here from Department of Health who might want to speak to this.
Thank you, Delegate Sickles. Any questions of committee? Anyone in the audience like to speak in favor of House Bill 2173? Please come forward and state your agency name.
Good morning. I'm Julie Henderson. I'm the Director of the Office of Environmental Health Services for the Virginia Department of Health. My office oversees bedding and upholstered furniture inspection. Senator Eben described the bill perfectly. I don't have anything else to add unless you have specific questions for me.
Okay. We won't. Anyway. Anyone else in the audience like to speak in favor of a senator's bill? Please come forward. Just kidding. All right.
Move to report.
Yeah, okay. I don't see anyone in opposition. I don't see anyone. Yeah, so, okay. We have a motion to report. Is there a second? Second. Okay. Any discussion? All in favor say aye, or vote on the board, please.
That happens all the time, but not in this big an audience.
Motion to report passes on a vote of 9-0. Thank you, Delegate Sickles. And that completes our docket. So thank you all very much.